So, any questions from the floor? Please.
I would like to ask two questions. The first question is regarding the screening colonoscopy. Should we just use the combination of endocup, LCI, and CAT-E? If not, sorry. So I would like to ask two questions. The first question is regarding the screening colonoscopy. What is the best suggestion for screening colonoscopy mode in your opinion? Should we just combine the endocup, LCI, and CAT-E? Okay, and the second question is regarding the ESD for the lesion, whether upper or lower, and it turned out to be T1B. Do you think that we can use the PET scan to exclude the regional lymph node so that we don't have to send this patient for the surgery? These are two of my questions. Thank you for the wonderful lectures.
The first question is scanning colonoscopy.
Okay.
What?
So
Only colonoscope or additional or adjunctive device? Cap, cup.
first question.
Yes.
So I remember. So there is a report. So the trial CAD, endocap plus IEE,
Yes.
but not to LCI. So in this trial, there is no add-on effect than LCI only, IE only, and endocap only. Slight elevated ADR is slight elevated, but no significant difference. But another trial will be elevated, so it's not controversial. Yeah.
That means in your opinion is no any difference, right?
Maybe endocap only.
Endocap only.
We can get a good result.
Good result, yeah.
And I also, so it's difficult to add on effect.
Yeah. Also one report, very good report from Professor Satimai Chorongkorn, also to prove this endocup any benefit to in terms of to get a good exposure of the mucosa. So I think the additional, even the transparent cap, endocup might be helpful for the screening. So the second question.
Oh, in the second question, in Japan, clinical trial is processing. So the T1 cancer in low rectum. So first ESD, and so the endoscopist plus chemotherapy and radiation is also useful, and so the patient avoids a permanent stoma. So this trial does not conclude yet, but we think in Europe, so the low rectum cancer, they select the chemotherapy and radiation therapy than the surgery. So
The question how about the PET scan, right? You mentioned the PET scan.
When we perform the ESD, and the lesion turned out to be the
T1B.
This from the standard, we say this patient for the surgery because we know that this patient have some risk of the low lymph node metastasis. But can we just use the PET scan to exclude the patient so that the patient don't have to perform the surgery?
So basically, T1B is a candidate for surgery, right? But any role for any technology to avoid surgery, PET scan.
They want to demonstrate that they have a
yeah.
lymph node metastasis or not.
No information.
Yeah, maybe.
I think no much information, right? Even not even PET scan, also the EUS as well. Because sometimes EUS can detect some small lymph node. But as Professor Maros already mentioned about the practice, T1B in Japan, in rectum, different from colon, right?
now,
Yes.
so the standard therapy is surgery or
Surgery.
operation, of course.
If the patient refuse surgery, what any option?
Selection, yeah, I think so. The endoscopic therapy is one selection, and but we will add the chemotherapy or radiation.
chemotherapy.
after ESD.
Especially in colon area, right? In the rectum.
We select this therapy, so it is important to dissect the tumor. Embryonic resection is most important.
Any questions?
Well, I have a question about the use of AI. Several studies have demonstrated that AI is very helpful for trainees or those who do not have much of experience. My question to the Japanese team and the Thai team as well is that in Japan, do you implement AI in routine practice for both experts and trainees in upper and lower endoscopy? Because, Nakamura, you show one case that you were able to detect a very small lesion when AI did not detect, and you insisted that that was a true lesion, right? And you went ahead and resect that lesion. I'm sure that it turned out to be adenoma, right? Yeah.
So for expert endoscopist,
Right.
maybe AI is not so not, but sometimes we are not fine. So the AI help us when we are not fine.
And do you use AI routinely in your practice?
If I can use, so yes.
You use AI, you apply AI to every case you do colonoscopy.
Yes.
Oh, okay. What about you?
In Japan, many doctors said detection ability of even expert endoscopists usually decrease in the afternoon compared with morning.
Really?
Yes,
It's-
because we usually feel tired. So, so many endoscopists want to use AI in the afternoon.
So is this for real?
Not joke. Yes, not a joke. It's
Not a
it's
joke.
real.
It is real.
Yeah.
Oh, okay.
Cases or not? Like if you perform more than 10 cases, we should introduce the AI at that time.
Because expert. No. No, over 50 doctors, including Professor Somchai.
Oh, okay.
It's helpful for us.
Okay, that's very good to know. Well, for the Thai team, I know that we do not have the availability of AI in both upper and lower. Professor Jirawat is developing AI for uppers. But I wanna ask Professor Jirawat though, where do you see the benefits of AI in upper GI endoscopy?
Thank you very much, Professor Nantli. Because of, as you know, the situation of Thai incidence of early cancer in Thailand is very low. So it's difficult to training for the trainee. So I think the AI system will useful and have a benefit for for help the beginners for detection of the suspicious lesion, both of esophagus and stomach, for particular for learning and for help them for for more increase of the notice or awareness of some lesion that they not familiar with before. Thank you.
Do we need to spend more time in a patient who have a oropharyngeal cancer and we want to see a simultaneous esophageal cancer or synchronous esophageal cancer? That should be spend more time or not, Professor Jirawat? Because as you already mentioned that maybe more than 20% that
Yes.
for 5 esophageal cancer in a patient who have an oropharyngeal cancer.
Yes, thank you very much, Professor Somchai. So we start the policy of the screening of both lesion of both primary because of before our knowledge of the early cancer came, we don't care about that, and so until now, our practice is all of cases of the high risk patient. Even though they don't have a history of oropharyngeal cancer, but high risk of the heavy smoker more than 20 years and with combined with alcoholic drinking. So we also screening of the oropharyngeal and the esophagus. So it take a little bit more time. So the AI will help to maybe increase the time a little bit. And I think one more thing is to increase the confidence of the can exclude the lesion or not.
Last question, actually. Dr. Oiporn has done a lot of work on AI, comparing among trainees and experts. Can you share with us the results of your study regarding AI?
Yeah, thank you very much, Professor Natri, for your question. We also get a big support from Fujifilm, and we have done a study looking at the ability or the performance of the cat eye for the characterization of the polyps. And our outcome have quite similar to what Professor Yamamura has shown, that the ability of the cat X to characterize between hyperplastic and neoplastic is about 80%, 83% around that. But it's just some difference between the expert and the trainee. The expert have similar accuracy for the characterization with the cat eye, but trainees are lower than the cat eye system. So our study also demonstrates that the AI for the characterization is good for the trainee, but for expert like Yamamura Sensei can detect a very small one and just only a white line, maybe he can diagnose the genet classification without magnification, right? But
his eye is a magnification.
yeah, Yamamura's eye, not cat eye. So yeah, the AI also both detection and characterization are good for trainee, but we have to discuss about for the expert. Like Miyahara Sensei said, it can help us to reduce the workload, the focus on that lesion. Yeah.
Okay, thank you so much. Yeah, and I might have to make a note that that study, the experts were trained by Nakamura. All right, thank you so much. So I think with that, we concluded the first session of the day, and now let me